Welcome back to Brain Pods. Here we are. We're on demyelinating disease, and I got Dr. Schmalstieg with me.
Good morning.
You will recognize Dr. Schmalstieg. He does some general inpatient work. MS clinic. Came to us via Texas, and then you did residency at the Mayo Clinic. Is that right?
Yeah, residency and MS fellowship at Mayo, and I came to the university in 2013.
That's right. And so, and we just finished our April blizzard. And we were just chatting about that, and he's probably wondering on occasion why he is here, as many of us do. But I really want to thank Dr. Schmalstieg for joining us today. We're going to review the basic pathophysiology and management of demyelinating disease, and you'll recognize the slides because they are an expansion upon the HHD5 slides that you got in second year. So let's just go ahead and get started. So demyelinating disease, various conditions, different etiologies, but what they have in common is a pathology either limited to or predominantly involving the white matter, which is myelin and oligodendrocytes. Not to say that gray matter, not to say that lesions can't occur in the gray matter, nor to say that axons are never involved, but that's just when we think of demyelinating disease, that's what we think of. But most, Dr. Schmalstieg, so your background is in neuroimmunology, right? Is that what you consider yourself?
Yeah, that's correct.
But because multiple sclerosis is such a common neuroimmunological condition, that's kind of much of the focus of what you do. Is that fair to say?
Yes, certainly in this part of the world, neuroimmunology clinic is going to be, approximately 90% multiple sclerosis.
Mm-hmm. Other places of the world, what else do they focus on?
Well, in Texas, for example, we would see probably a higher percentage of things like CNS lupus,
Okay.
Which is relatively unusual here. Now, there are ethnic groups in whom multiple sclerosis is quite rare, and in Asia, for instance, neuromyelitis optica is probably at least as common, if not more common, than multiple sclerosis overall.
Sarcoid fall under neuroimmunology, or is that?
It does. Usually in our clinic we see CNS sarcoid. Sarcoid can involve really essentially any organ system in the body, and it is something that we see from time to time. But it's at least an order of magnitude less common than multiple sclerosis.
Got it. Okay, so the signs and symptoms of demyelinating disease can affect almost anything in the CNS. So unlike other pathophysiologies where the localization often tells you what the underlying process and etiology is, this demyelinating disease can really be all over. We're going to talk about 4 conditions. The bulk of our conversation is going to be talking about multiple sclerosis. There is neuromyelitis optica that Dr. Schmalstieg just mentioned. We'll also talk about acute disseminated encephalomyelitis, usually occurring in children, and progressive multifocal leukoencephalopathy, nearly always occurring in the setting of immunosuppression. All right, we're going to just go right into multiple sclerosis. So MS is an immune-mediated inflammatory disorder, results in numerous, i.e. multiple, intermittent white matter attacks, and on pathological evaluation, post-mortem pathological evaluations, these chronic plaques had a sclerotic appearance, which is my understanding where the name of MS came from. Is that fair to say?
That's right.
Crushed it. All right, great. And this can occur anywhere in the neuroaxis. That being said, there are a couple giveaways that sometimes can be quite helpful. The myelin of peripheral nervous system is not affected. So this affects myelin from oligodendrocytes. It does not affect the myelin from Schwann cells. And here is just a little picture of just a reminder of the neuron, the axon, the dendrites, and of course the communication occurs faster across myelin through these nodes of Ranvier that cause these saltatory conductions, boom, 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 real fast. Otherwise, if you have a neuron without myelin or very little myelin, you do get conduction. It's just a lot slower, and the slower the conduction, the less functional it is. And so most of the time, you get this attack of the myelin, and it ends up with a damaged myelin sheath here, but the axon is still intact. Now, there are some exceptions to that in the case of severe demyelinating disease attacks, but just in general, you can think of axons as typically being spared. Fair to say?
In the early stages of MS, the relapsing remitting stages of the condition, the immune system is attacking that myelin insulation around nerve fibers. In the long term, particularly in the progressive stages of MS, which we'll talk about here in a few minutes, those underlying nerve fibers eventually get damaged, and that's actually the substrate of permanent disability in people with MS. Is those nerve fibers get injured over time.
So when you see an MS patient who's in a wheelchair or spastic, that there is some degree of axonal damage there. Is that fair to say?
There is, and that's those permanent and irreversible deficits are what we typically associate with neuronal injury, because the myelin does have some potential for repair, whereas neurons, as you probably know in the CNS, don't have much meaningful potential to regenerate.
Got it. Multiple sclerosis, far more common in women than in men. Game of Thrones guy at all, Dr. Schmalstig? Have you seen the show?
A couple times.
A couple of times. All right, fair to say. So, and often it tends to occur in young adulthood, which brings us to the geographical variation that has been characterized with multiple sclerosis going back a long time. And this has been noted particularly in North America, the idea that the higher the latitude that you are, the greater the prevalence of multiple sclerosis. Now, my take on this, this always needs to be considered in light of the fact that, well, we tend to have, there tends to be more Scandinavians, similar ethnicity that have settled in northern hemispheres, so that may be part of the story. In addition, this is also seen in the southern hemisphere as well, isn't it? So Australia, New Zealand, which again gets into kind of that northern European settlement. I remember when I was in residency, there was even a few studies that took a look at Caribbean migrants. So if someone was native to the Caribbean but moved at a young age to a northern latitude, they had a higher incidence, higher risk of developing multiple sclerosis than those who stayed, and vice versa. Now, where are we on the latest on this thinking, Dr. Schmalstig?
So regarding the geographic variation, again, the idea is that basically the farther away you live from the equator, the higher the incidence of multiple sclerosis seems to be. So if you live farther south in Australia or farther north in North America, you have an increased risk of MS. Now, as to the question about ethnicity and there being kind of more people of Northern European ancestry and as a proportion of the population of Minnesota as compared to, say, Mississippi, that's certainly true. The best study on that was actually a study from the VA that looked at white male veterans and found that geographic variation still holds up even in that presumably somewhat homogeneous group of people, and it's about a twofold increase in MS risk in say Minnesota or versus the Deep South. Now, regarding the question about migration, it seems that there's a critical period, and what really has the most influence on the risk is where one lives during late childhood and adolescence. That seems to be the if you move when you're 25, your MS risk stays like the place where you originated. Whereas if you move when you're 5, then you look more like the people in the place where you migrated to rather than the place of birth. Yeah.
In vitamin D, environmental exposure. I mean, what any latest thoughts on why this is?
So there have been, and the best data on that particular subject is probably from Australia. They've actually found an inverse correlation between MS risk and how much sun damage one has to skin. So if you do the right things to keep yourself from getting skin cancer, you may be raising your risk of multiple sclerosis slightly. The only thing that we really that I know of, and I think that anyone's aware of, that is linked to UV exposure to the skin is vitamin D, and so there's a lot of and there have been epidemiologic observations that people with lower vitamin D levels have an increased risk of MS and potentially even a more aggressive course. There are people who will hypothesize that maybe there's some other undetected factor associated with sun exposure, and vitamin D is an epiphenomenon. So the vitamin D hypothesis is not proven, but it seems like the most logical explanation.
Fascinating. More to come. All right, so let's just talk a little bit about the etiology of a multiple sclerosis and multiple sclerosis attacks, and we'll just kind of walk through it here. So like all autoimmune conditions, there's some triggering event in the setting of uncertain environmental genetic factors. Then inside the blood there's an activation of B and T lymphocytes. These lymphocytes will ultimately penetrate the CNS through venules through the endothelial cells in the venules. So this is a venous infiltration, right, as opposed to an arterial infiltration. Is that fair to say?
I think that's generally what's presumed to be accurate. Yes.
Yeah, and then they cross the blood-brain barrier, and it's then you get the white matter inflammation, and you'll get a activation of lymphocytes, microglial cells, and macrophages. There's a combination. Then there's a milieu of cytokine release. And then it's the macrophages which damage the myelin sheath, and you can get oligodendrocyte loss. Sometimes it just stops. Sometimes the attack stops there. Other times, in more severe inflammation, you get the axonal loss that we were talking about before. And then if you go over time here and you look at chronic changes as months pass, if you're talking about just the neurons that had the myelin sheath damage but still had intact axons, on MRI scan you'll see the plaques on the MRI from the sclerosis and from the myelin loss, but the axons are preserved. Conversely, if you look at the areas of the brain where you had the severe inflammation and the axonal loss, over time you'll end up with these black holes on MRI due to the loss of both myelin and axons. Any thoughts on this kind of conventional, somewhat simplified version of the inflammatory cascade?
Yeah, I think all of this is generally accurate. One comment that is of some interest is these MRI markers like black holes and just gross atrophy of the brain that actually correlate most strongly with permanent disability in MS. Again, emphasizing the point that it's actually injury to the axons at the ultimate substrate of disability.
Right. So let's just talk about how these patients clinically present. I'm often struck, Dr. Schmalstieg, by when a patient often presents with multiple sclerosis and they get their first MRI scan, there's often a lot of plaques already there, suggesting that they've had they've had attacks already that went unnoticed. Is that fair to say?
Yeah, and I think that's maybe as much as 10 to 1, you'll see some evidence of disease by MRI at the time that the patient first presents clinically. Occasionally they'll have had subtle events in the past that they just kind of recall in retrospect. And of course we do see an occasional patient in whom we really do seem to be seeing the very first white matter lesion they ever had. But it is striking how many of these patients have had disease for an undetermined period of time by MRI by the time we see them for the first time.
So this is a classic MRI picture. You're looking on a sagittal view, and what you see is these white matter lesions, which tend to have a streakish appearance that radiate up from the corpus callosum. And my understanding of this is where the venules are, right? The venules kind of have this striated appearance.
That's correct.
Yeah, and so you get this very typical MRI picture. which is you get a lot of disease. There's a lot of diseases that affect the white matter, but if you have this characteristic MRI, you really can have quite a bit of confidence that you're probably dealing with multiple sclerosis. And also, I don't know the age of this person that we're looking at, but you can tell that there is a lot of atrophy. You can see the sulci very easily, which makes you think, as Dr. Schmalzig just mentioned, that we're not talking just about white matter lesions, but there's, because of the atrophy, that indicates that there's actually gray matter axonal loss as well. And depending on where these plaques are, you can commonly get either hemiparesis, or weakness on one side of the body, or hemiparesthesias. A couple other very classic demyelinating disease lesions, one of which is optic neuritis. This is an inflammation of the optic nerve. It causes painful monocular visual loss, monocular because it's anterior to the optic chiasm. Remember, once we get past the optic chiasm, if you have a lesion in the system, that results in a field deficit, not a monocular deficit. In addition to that, unlike other pathologies to the optic nerve, optic neuritis is a painful process. And the way I think about this is the optic nerve does not have a lot of space, and if it's inflamed, you can cause pain, and the pain particularly happens when you're looking from side to side. And the way I think about that is that the optic nerve, when it's sitting inside your orbit and is looking straight ahead, there's a little slack to it, and then as you turn it, it kind of tightens, and if there's inflammation in there, it's painful. I don't know if that's the right way to think about it or not. But
the optic nerve is, we call it a nerve, but it's really an extension of the CNS to the back of the eye. And like all CNS fibers, the nerves themselves don't have pain fibers.
yeah,
So it's presumably, just as you say, the nerve is swelling up and is putting some stretch on the meninges. And in the setting of that swelling, particularly moving the eye, irritates those meningeal pain fibers that are being irritated.
so this is, you get monocular visual loss, sometimes blindness, sometimes just intense blurriness. Another classic demyelinating disease lesion is a lesion of the medial longitudinal fasciculus, which links horizontal eye movements. Now we have talked about this before in other brain pods, but it's worthwhile to think about. So, in order to coordinate horizontal eye movements, you need a link between the ipsilateral cranial nerve 6, which is going to move the eye in the lateral direction, and the contralateral medial rectus, which comes from cranial nerve 3, and you're talking about from down in the pons all the way up to the quite high in the midbrain, and that results in a, as far as the brainstem is concerned, a fairly, a pretty good deal of territory of a long fiber tract, which is all myelinated, and so it's vulnerable, right? So there's a lot of different areas along that pathway that you can have a demyelinating attack. And you can get a lesion of the medial longitudinal fasciculus from, say, a stroke, but in general, you tend to get bilateral lesions of the medial longitudinal fasciculus from demyelinating disease. And the reason why that is because arterial infarcts tend to respect the midline and don't cross to the other side. And so what ultimately happens then is, so this woman right here is trying to look to the left, and this is a lesion of her right medial longitudinal fasciculus. So cranial nerve 6 and lateral rectus is fine, but her adducting eye, her right eye, is not able to look medially. And we frequently see this in demyelinating disease, and if you have bilateral intranuclear ophthalmoplegia, so if we were to ask her to look to the right side, the right eye could abduct normally, but the left eye would not be able to adduct. Anything to add on INO, Dr. Schmalzig?
Yeah, this would be a particularly severe example, as you might see if there have been fairly destructive lesion in the brainstem. Many INOs in MS are quite subtle,
Yeah.
and one of the more noticeable things is actually nystagmus of what's actually the normally functioning eye as the patient abducts that eye, because essentially the cortex is trying to compensate for disconjugate movements of the eyes because the trailing adducting eye is slow.
And here's just a picture of what that looks like. So here's cranial nerve 6, able to pull the lateral rectus. It's this medial longitudinal fasciculus that's 6 through the paramedian pontine reticular formation, courses all the way up to the medial rectus. And so you can have a lesion right here, but you can also have a lesion here or here or here or here. And so there's a lot of territory. And so these are vulnerable tracts. Worthwhile to think about the cord. The cord has a lot of myelin in it, and if you happen to like anything that happens underneath your chin, you like your cervical spinal cord. In multiple sclerosis as well as in neuromyelitis optica, we very frequently can see demyelinating attacks that involve the spinal cord, and so it can result in all sorts of problems, including quadriparesis, hemiparesis, bowel bladder dysfunction, sexual dysfunction, and a particular Lermite sign, which is when you ask someone to just flex their chin down to their chest, they get a lightning-like sensation that goes up and down the spine. And do we have a mechanism for how is that? Dorsal column involvement? What is the reason for that?
It's exactly why that occurs is not something that's known, at least to me, but it is classic sign of dorsal column involvement. It's not specific for demyelinating disease at all.
No.
You can see that in neurosyphilis and essentially anything else that affects it's really a marker of dorsal column pathology, but it's quite common in MS. It also is something that is often helpful to ask people about because it may have been something that occurred in the past that people just kind of think is a tribute to a pinched nerve or something
Sure.
of that nature. So it certainly doesn't occur in every patient, but relatively common sign that we can pick up on.
All right, which brings us to Uthoff's phenomenon. And my understanding of this is that you have someone who has multiple sclerosis, so they've had attacks in their myelin, and the myelin in those neurons where the axons are still intact, and the myelin was damaged, but now it has remyelinated, although it has not remyelinated as nicely as it did during our early development. And so there's some degree of impaired saltatory conduction. That's the jumping conduction across the nodes of Ranvier. And so you can impede that conduction is impeded with higher temperature for reasons I could not quote you off the top of my head. So anything that results in higher core body temperature, whether or not that's a fever, whether that's taking a hot bath, or you're in it's in the hot humid summer when your air conditioning broke down, you'll get a reemergence of symptoms. And the key here is that these are not new symptoms that they haven't experienced before. It's just a reemergence of their old symptoms. Anything to add on Uthoff's?
Yeah, this is the physiology is probably not something we need to get into, but you can think of it basically as heat essentially interferes with the conduction of nerve impulses across these demyelinated segments, and results in these transient periods of worsening. It's always important to emphasize to patients that symptoms that resolve in a matter of minutes or even hours are very unlikely to be due to new inflammation in the central nervous system. Inflammation just doesn't resolve over that time course. So if you see someone who has an hour of blurred vision in the setting of a diagnosis of MS, very often you'll find that they're either ill with something like urinary tract infection, or perhaps they just became overheated due to exercise or ambient temperatures.
Is 24 hours a critical threshold? Is that kind of where you start thinking to yourself, if something is, especially if something's new when it's been going on for more than 24 hours?
That's the minimum period of time that we have to set sort of a marker somewhere and say that this is kind of the shortest period of time that a new symptom could credibly be an MS relapse. In reality, depending on severity, most true relapses last for many days to a period of several weeks or even a few months.
Got it. So how do we diagnose someone with multiple sclerosis? Because there are numerous conditions, numerous processes, vascular infection, other inflammations such as sarcoid, neoplasm, that can lead to brain and white matter changes. But to be diagnosed with multiple sclerosis, is again gets back to the name. There must be evidence either clinically or on an MRI scan of lesions, multiple lesions that are disseminated in both space and time, meaning that they're spread out throughout the course of the brain, and these have occurred at different times. And clinically, this results in a threshold of at least 2 classic MS type attacks, like we talked about before: optic neuritis, internuclear ophthalmoplegia, spread out over time, and as Dr. Schmalstig just mentioned, that the minimum threshold is at least 24 hours. Now, MRI has really revolutionized our diagnosing MS before MRI scan was quite different, but it has allowed us to get a jump on patients, so you don't have to wait for them to have 2 clinical attacks. So if you see patients who have multiple plaques in classical MS locations, like those paraventricular fingers I showed you before, and they look to be of varying ages, and what that means is that new lesions enhance when you give gadolinium enhancement, because that is a marker of a breakdown of the blood-brain barrier. And if you have some lesions that enhance, that means they're new, and if you have some lesions that don't enhance, that means they happened previously, so that means they're old. Any other thoughts on coming to the criteria for this? Always seems like it changes every 5 years or so.
Yeah, and they were changed again last year. Memorizing the diagnostic, as with most diseases, I mean, ultimately these diagnostic criteria are primarily for the purposes of research studies. So we know that people that we're enrolling have, we all agree on what the condition is and what defines it. But MRI has certainly changed things in MS diagnosis, and it's made it possible to diagnose people whom in previous years would essentially have had a suspected diagnosis of possible MS or probable MS and move them into that definite category. Mm-hmm. So it actually has had an effect in particularly in the research arena, in that if you look at people in trials that are conducted in 2015, they're just not as sick as the people who were in trials that started in 1988, and that's really attributable to MRI and its ability to make a more a firm diagnosis earlier. So we're diagnosing a lot of people who are less ill.
Which is good, I mean, because it gives us the hope that we'll help prevent more aggressive disease. Yeah. Okay, so CSF evaluation via lumbar puncture, oligoclonal bands, which is, you can see, so normal here is you have an absence of these bands on CSF analysis, and then an abnormal when you have an enhanced oligoclonal bands. This is an increase in IgG, I believe, and it tends to indicate an lymphocytes in the CSF. Is that fair? How am I doing?
Yeah, these are antibodies ultimately that you're detecting that we're detecting on a gel. And the critical thing that's being shown on the slide here is that these are antibodies that are seen in the spinal fluid, and they're individual. This isn't just a smear of a wide number of antibodies. It's a relatively limited clonal repertoire from the lymphocytes, and we're seeing this in the spinal fluid and not in the serum.
How important is CSF evaluation in MS diagnosis? I mean, is it something used all the time? Is it something used only in challenging cases?
In my view, it's with what MRI has allowed us to do, it's I think fair to say it's less important than it was 30 years ago. Although it is still a very helpful confirmatory test, and there seems to be any doubt about the diagnosis. Depending on how many bands one considers abnormal, 90 to 95% of people with MS do have these oligoclonal bands in serum, in CSF rather. But one thing that is important to realize is that implicit in that statement is that at least 5% of people who have MS by any reasonable criteria don't have this finding.
Okay.
And there are other rarer conditions, things like sarcoid lymphoma, occasionally Lyme disease, that can make these bands appear in the CSF that are not MS. So ultimately, it's neither necessary or sufficient for the diagnosis. But when you have a suggestive clinical presentation, you see oligoclonal bands in the CSF, that about clinches it.
That clinches the diagnosis. when you have a patient with MS, whether or not you're seeing them in a clinic for other reasons, whether or not you're a neurologist, you're a hospitalist taking care of this patient, you'll frequently see how their MS is characterized, and it's at least initially the two conditions are relapsing remitting multiple sclerosis versus primary progressive multiple sclerosis. The difference there is that in relapsing remitting multiple sclerosis is that the patient returns to a baseline between attacks. And then later, ranging from years to several decades later, the patients with relapsing remitting multiple sclerosis will have a progression of symptoms between attacks and are ultimately called secondary progressive. And as we learned before, the conversion of relapsing remitting to secondary progressive indicates that there is a substantial burden of axonal loss. Of the patients with relapsing remitting MS, what percentage will ultimately go on to secondary progressive?
More than 50%
Yeah, okay.
will eventually develop a secondary progressive course. And again, the severity can widely vary widely among those patients as well.
Primary progressive, is this a different disease?
That's a question to which there's ultimately no entirely clear answer. I suspect, these terms that we're using here, they've been long established, and I don't think they're going to go anywhere. But it really is probably insufficient to describe what we're most interested about in terms of pathology. Progression, as you said, ultimately means that we're seeing injury to the underlying axons. The other thing that we're interested in is whether there is active inflammation. That's really the biggest question in terms of disease-modifying therapies for MS. So I think that the vast majority, my personal bias, the vast majority of patients with primary progressive MS have the same condition, and for whatever reason, that kind of early inflammatory phase of their disorder was not very prominent. So what's interesting is that people with primary progressive MS look demographically very similar to people with secondary progressive MS. They tend to be older when their symptoms start. So it just kind of looks they look very similar to the secondary progressive patients. It's just that they didn't have that initial relapsing presentation.
Got it. And here's a couple nice tables that just kind of show what we're talking about. So on the x-axis here is time, and on the y-axis, the higher you go up, the more disability. So here's relapsing remitting. As you can see that someone is going along, they have an attack, but they come back to normal. Then they have a couple more attacks, and then ultimately they start progressing subsequently. They have attacks, but they don't. I think I should correct this. So sometimes they don't quite come back to baseline. So you can have relapsing remitting multiple sclerosis and have permanent deficits and not be secondary progressive. Is that right?
Yeah, you can have, the general rule is people either at least partially, if not completely, recover from these relapses. It's relatively rare in multiple sclerosis to have a single relapse that produces permanently incapacitating disability, but it can occur. Sometimes someone just has a really bad attack, and then just the inflammation from that will produce a permanent deficit.
But here in secondary progressive, so they initially just had attacks and relapses to baseline, but then they start to have this progressive. You can't even identify specific attacks. They just have this decline in function. And in primary progressive MS, it just starts right from the beginning. And so what I think I heard Dr. Smolstik said is that these people when they're here look a lot like these people right when they present.
That's right.
Okay. So in general, the prognosis is better if you're younger. Conventional wisdom makes sense that the shorter the attack is, the more likely you are to have a good recovery. The longer the remissions, all the better. What do we do? So when someone first comes in, you use high dose corticosteroids, knock down the inflammation. When I was taught, Dr. Schmalstig, I was taught that the steroids help hasten the recovery of that attack, but ultimately the outcome is essentially the same as whether or not they get, with the exception maybe being of optic neuritis. But
actually, it's thought to be the case in optic neuritis as well. No study has ever showed very convincingly that that there's any effect on actual long-term outcomes based on whether you get steroids or not. So, at least as a matter of averages, you're probably going to end up in the same place whether you get steroids or not. But steroids will help you get better faster. Yeah. And whether or not to give steroids largely depends on how impaired the patient is by the symptoms. I mean, if you're blind or you can't walk, I mean, I think almost everybody would want that to go away as fast as possible. Yeah. You know, if your little finger tingles, it may not be as easy a decision.
Acute attacks after we've tried corticosteroids, or maybe if they can't take corticosteroids, other strategies. I have plasmapheresis up here. Is that kind of the typical strategy?
Yeah, plasmapheresis is often used as a rescue strategy for patients who have had severe attacks unresponsive to corticosteroids. There is some limited data suggesting that the prognosis with patients who get PLEX may be better than for patients who don't get that treatment. So it may be truly disease modifying, at least in people with these very severe attacks that are resulting in things like blindness or paralysis. Plasma exchange is something that we would virtually never use for a very mild attack that was sensory predominant. It's really these things that are going to be functionally incapacitating if they don't go away.
Is there a role of IVIG?
There is not any clear benefit. There was a lot of interest in IVIG for MS about 10 years ago, a lot of studies done, most of which didn't really meet their primary endpoints. It is occasionally used still in some places, but I would say that that'd be definitely a third line option if you believe in it at all.
Okay. Which brings us to disease-modifying therapy. So steroids, plasma exchange, they don't alter the overall course of the condition. But when I was, the last time I took my board exams, which was 10 years ago, this was all we had to talk about, or at least, you know, in my world as a general neurologist, this was all I was really aware of. These first-generation injectables, these are these interferons, or gluteramine acetates injectables, depending upon which one it is. It's either every day, every other day, once a week. And my read, I haven't taken care of a lot of MS patients for the last 10 years. My read is that we still often try these medications first. Is that fair to say?
You will never see a question in the USMLE of what is the best initial treatment for MS, because there's no consensus on that whatsoever. The very broad overview on these is that we have medicines like these first generation drugs that are very safe, but are not as potent as some of the newer therapies. Okay. The issue with the newer drugs is that as a trade-off for that potency, you're accepting low but not zero risks of potentially very serious side effects with many of these drugs.
Such as progressive multifocal leukoencephalopathy, which is a reactivation of the JC virus, which my understanding is about half of us have it sitting in our oligodendrocytes anyway, and if you happen to be JC virus positive, you are at higher risk of developing progressive multifocal leukoencephalopathy. These agents, my understanding of the first generation agents is that they affect that cytokine cascade, right? And the second generation agents, there's some variability to them, but they do deal with everything from lymphocyte activation to trafficking across the blood-brain barrier. So they're just more potent at suppressing the immune system, suppressing the inflammatory response, which of course is good in MS, but potentially opens the door for conditions like progressive multifocal leukoencephalopathy.
Yeah, we use this buzzword for drugs like gluteramine and interferon as being immune modulatory, rather than making the immune system less likely to recognize itself, whereas many of the newer drugs are clearly, to one extent or another, immune suppressive. Okay. Of the agents listed there, dimethyl fumarate, which is one of the oral preparations, is the only one to whom that probably doesn't apply. The mechanism of action of dimethyl fumarate is really truly unclear in terms of exactly what that drug, very simple compound does.
The other advantage here is that some of them are oral, so they're just tablets you can take. And then the infusions, are these once a week, once a month, quarterly? How often do the infusions go in?
So There's 4 IV medicines for MS. Natalizumab is monthly. Alemtuzumab, which you have listed here, superficially sounds quite nice. You get 5 IV injections 1 year, and then you come back the next year and get 3 days of treatments, and then many patients can go for years without needing other treatment after that course. The trade-off for that is that there is ironically a high incidence of developing other autoimmune conditions after alemtuzumab treatment. So about a third of patients, for instance, will end up with autoimmune thyroid disease at some point in the future after that treatment. There's a new drug called ocrelizumab as a B-cell depleting agent that's every 6 months. Just for total completeness, the other one's not listed here is mitoxantrone, which is an old, fairly toxic chemotherapy that's quite rarely used now because its side effect profile is not very favorable compared to newer agents.
Got it. Okay. Well, it's exciting though because we have a lot more tools in which to take care of. There's a lot of people who for all practical purposes, we can essentially place in permanent remission or nearly close to it when it goes well.
In terms of the inflammation, it is a rare patient now in whom we can't shut down the inflammatory aspect of disease. The question is, to what extent have we by the time we get to treat a patient, to what extent are they already sort of fated to have long-term axonal degeneration due to the damage to the myelin that's already occurred in the past?
Got it. All right. Well, just like all neurological conditions, we also, especially if there's a lingering deficit, we need to think about supportive therapy. So spasticity. If this is involving white matter tracts of the cortical spinal tract or cortical bulbar tract, you can think about baclofen, which is a GABA B agonist, tizanidine, which is an alpha-2 adrenergic agonist. Painful paresthesias are common. These are the alpha-2 delta ligands, the gabapentins, the pregabalins. Urinary incontinence is just incredibly common in the setting of spinal cord disease. And the muscarinic antagonist oxybutynin is helpful. Sexual dysfunction, when I looked at the data here, is actually sildenafil has efficacy for both men and women, even though we sometimes think of it as just a tool for male sexual dysfunction. Antidepressants for depression, and then our colleagues in OTPT and speech language pathology are really comfortable taking care of people with MS because they have so much experience with them. Any other thoughts?
Many of these, I'd emphasize here is that many of these, particularly sexual dysfunction, are not things that people will tell you about if you don't bring it up. And sometimes even if you ask a question, do you have any problems here? People will say no because they're sort of embarrassed to talk about these issues. So sometimes it's helpful even to bring up that these kinds of problems are common in people with MS, even as it's an open-ended part of the conversation. And it's surprising how much of the time, once you sort of, we give people permission to talk about these things, they'll say, well, now that you mention it, I do have that problem.
Yeah, it's almost to be expected, sexual dysfunction and urinary incontinence if you have, at least to some degree, if you have a spinal cord lesion. I mean, it's multiple sclerosis is common in young women, so pregnancy is often an issue that comes up. What happens to the attacks during pregnancy? My simple understanding about this is that the attacks during pregnancy decrease. There is overall an increase in attacks postpartum, and overall the course is unchanged.
Yeah, that's all correct.
All right, great. Which brings us, so that was multiple sclerosis. This brings us now to neuromyelitis optica. For most of my career, I thought of neuromyelitis optica as essentially being a subtype of multiple sclerosis. It's more, I think of it now as a more aggressive disease. There's more gray matter involvement. The therapies we have are not as effective. And the name itself kind of tells the story. So you have a combination of inflammation of the optic nerves. So they get a lot of optic neuritis, painful monocular vision loss. And then they get these spinal cord lesions. So you can get spinal cord lesions in MS, but in neuromyelitis optica, you get this more confluent, more extensive spinal cord attacks, which can lead to progressive paraparesis, quadriparesis, paraplegia, quadriplegia. And then I know this isn't a source of active discussion, but I think as far as a third-year medical student is concerned, if they think of aquaporin 4 as being equivalent to neuromyelitis optica, I think that's probably pretty reasonable. Although there are some cases of neuromyelitis optica that do not have positive antibodies to this aquaporin 4 channel. Other thoughts on myelitis optica?
Yeah, I think the most critical thing to realize, it's been recognized with the discovery of aquaporin 4 antibodies in the last 20 years that this is clearly a distinct and separate disease from MS. The disease-modifying therapies for multiple sclerosis do not work in NMO, and in fact, several of them almost certainly make this condition worse. So you don't want to confound and misdiagnose NMO as MS. The one area of overlap is in B-cell depletion. Agents like rituximab do seem to be effective for both conditions. So if there is a situation in which you don't, you really are not sure which one is right, it's probably best to err on the side of treating them for NMO.
Got it. On to acute disseminated encephalomyelitis. This tends to be a condition of children. At least I don't ever remember seeing it in an adult. It is it's an acute monophasic inflammation of white matter. I changed this. I had a previous version of this slide that called this an acute monophasic demyelination of white matter, but after talking to Dr. Brent Clark, who indicated that this is mainly an inflammation of the white matter, there's very little to almost no damage to the myelin, permanent damage to the myelin itself, which is why their prognosis is so good. They after the acute monophasic event, they often do quite well. This is often seen after an infection or a vaccine.
Yeah, what you see pathologically in ADEM is just these sheets of lymphocytes around vessels. It's not a vasculitis. It's not destroying. You see basically perivascular inflammation. This looks like almost a direct autoimmune attack against myelin. The pathology of ADEM actually looks very, very similar to what we see in the mouse model of MS called experimental autoimmune encephalomyelitis that is induced by injecting myelin into mice.
Mm-hmm. But does the myelin survive relatively intact? Is that fair to say?
It does. This is mostly a non-destructive process, and these kids, the vast majority of them will get better, even though they can be very ill and very encephalopathic at presentation.
This is what I found in terms of the treatment. Anything to add besides steroids and plasma exchange?
Yeah, it's steroids. Most of these kids will respond to steroids. Just as with MS, if you have someone who appears to be critically ill and is not getting better, plasma exchange would be second-line therapy.
Go ahead.
Yeah, this might be one area where IVIG would be another part of the strategy. If we saw someone who had a corticosteroid refractory course.
Got it. And then finally, progressive multifocal leukoencephalopathy, which is a AIDS-defining illness back in the era before heart therapy or in patients who have not been on antiretroviral therapy. You can still see this, which is a emergence of this JC virus in the oligodendrocytes. It is a catastrophic disease to the myelin. You get these very confluent, non-remitting pathologies. It is, in addition to being associated with HIV/AIDS, however, it is also commonly seen in those new generation MS agents that we were talking about. So you have this situation where patients do unfortunately have to take a bit of a risk, which is in order to save their white matter from demyelinating disease attacks, they do open the door slightly to increased risk of progressive multifocal leukoencephalopathy. I think we can decrease, we can kind of classify who's at higher risk of this by doing JC viral titers, right? Is it the virus titers, the antibody titers, or how do we?
Yeah, so the biggest risk factor is whether, obviously, you have, as you said earlier, whether you have the virus or not. This is a virus like chicken pox that once it's in your body, you've got it. It's never gonna,
Yep.
never gonna go away. But if you have a normal immune system, it virtually never causes any problems. When the immune system is compromised by advanced HIV, by certain hematologic malignancies, as well as now increasingly seen with some of these medications, the virus can reactivate in the brain and cause this very serious infection. One thing on this slide I would say
Yep.
is that the prognosis of PML really actually depends on what the underlying cause is. If you get this in the setting of chronic lymphocytic leukemia, it's a very poor prognostic marker indeed. That's probably not going to be survivable. If, on the other hand, you can remove the whatever the stimulus is that's suppressing the immune system will eventually come in and kill the virus. So, in the setting of someone who has had HIV and doesn't know that they have it, if you put them on highly active antiretroviral therapy, they can sometimes recover. And actually, in the MS patient population with natalizumab, which is the drug that this is most closely associated with, the fatality rate is about 25%.
Okay.
Many of the patients actually survive. Unfortunately, of the survivors, probably more than half will still end up with a permanent deficit. However, so this is bad. You don't want to get this.
Here's just a picture of what this looks like. So as we go from over 1 to 3 years, you can see this emergence of white matter lesions that end up being very confluent, progressive, and ultimately taking up much of the white matter. And this is natalizumab associated PML. Well, great. Thank you very much, Dr. Schmalstieg. We'll be going over peripheral neuropathy next time with Dr. Nathan Sipt as well as Dr. Rami Asadi. Students will get a chance to meet you on the inpatient service and sometimes in the EMS clinic. Is that right?
Sounds good.
All right, great. Thank you, and we will see you next time.